So I'm going to talk about some aspects of bowel obstruction. And I've borrowed some of this talk from a paper that Bill Thompson and I wrote a couple years ago, published in Radiology. You know, the surgical textbooks say that you should never let the sun rise or set on a small bowel obstruction, but that's not the way these patients are managed at all. Most patients with a small bowel obstruction are treated conservatively with NG tube decompression, and they're watched closely, which I think is probably appropriate. And while small bowel obstruction accounts for about 1/5 of hospital admissions for patients with the acute abdomen, most patients with small bowel obstructions with NG tube decompression do fine, and they resolve without surgery. Yet there's a substantial morbidity and mortality in a subset of patients with small bowel obstruction, right? And those patients may go on to have strangulation or ischemia or complications from small bowel obstruction. And clinical exam is not particularly helpful at predicting those patients, and laboratory tests aren't particularly helpful for stratifying those patients either. So we're called on to provide that stratification by imaging. And so let me talk about that dilemma. How do we stratify patients with SBOs into those who have something a surgeon should fix tonight versus have something a surgeon can probably watch? So before I get there, first of all, a lot of patients get radiographs for small bowel obstruction. The accuracy's not bad. It's like 50 to 80%. I think experience matters. I worry that with our younger generation of radiologists, their diagnostic skills on radiography are less than when many of us came through. I try to avoid this term, the nonspecific bowel gas pattern, in my reports. And just a reminder, both supine and prone films help in diagnosis. This is a classic case of a small bowel obstruction where you see dilated proximal small bowel, decompressed distal bowel, decompressed colon. On an upright film, you have air fluid levels. You may have little bubbles of air trapped in between the valvulae conniventes, which create this string of pearl signs. You have an absence of gas in the rectum and the sigmoid typically. And you know those classic radiographic findings. Often patients with suspected small bowel obstruction undergo CT, and the sensitivity and the specificity are higher than radiography, in the order of 90% or so, with overall accuracy for the diagnosis and exclusion of small bowel obstruction of about 90%. And as I was talking about this morning with acute appendix, I think the multiplanar reformations, which I think are routines in all our practices these days, improve our confidence in the ability to identify the specific point of transition in small bowel obstruction. So we like CT for the diagnosis. We're confident in the diagnosis. We can not only diagnose a small bowel obstruction, but point to the transition from the dilated bowel to the decompressed bowel, the transition point, and at that transition point, you can look for the specific etiology of the small bowel obstruction, and perhaps most importantly, look for findings that may predict complications or look for the presence of complications that require prompt intervention. And here's the CT of a high-grade small bowel obstruction. High-grade, what does that mean? One definition is greater than 50% increase in diameter of the small bowel from proximal to distal, and in this particular case, that's clearly at least 50%. It's more like 500% increase in distension between proximally and distally. I talked about this a little bit this morning, but we've really cut back on the use of oral contrast. It's controversial, and a lot of groups disagree with our practice. Patients don't particularly like it. The large volume is consumed inconsistently, and frankly, we don't care, typically. In sick patients, and a lot of my practice is hospitalized patients, they often throw up or have diarrhea caused by oral contrast. That's not the case with outpatients. Patients often can't drink the volume that we ask them to drink, and it's time-consuming. Some pharmacies now call oral contrast a medication, and so you can't give it like you used to. We're supposed to opacify the entirety of the bowel, but we usually do not succeed. And often we don't rescan patients anymore after contrast is not given or contrast is incomplete. So we've, for many indications, have really cut back the use of oral contrast. We definitely don't use it when we're looking for a small bowel obstruction, when we're looking for an acute GI bleed, when we're looking for ischemic bowel, when we're working up acute appendicitis or diverticulitis, when patients have trauma, and for many oncology patients, when they come back for repeat scans, we don't use oral contrast. In regard to causes of small bowel obstruction, in patients without a known primary tumor, in all comers, about half of them will have adhesions, usually from a prior surgical procedure or some prior peritoneal insult. Hernia, about 15%, and undetected unknown neoplasms in about 15 or 16%. In patients with a known primary, however, peritoneal metastases like this one seen right here causing this small bowel obstruction account for about 60% of patients with small bowel obstructions. The thing about the peritoneal metastases causing small bowel obstruction, surgeons are loath to operate on those patients because if there's one peritoneal metastasis, there's likely others on the serosa or in the wall of the bowel. And so a surgeon's not going to want to go resect one peritoneal metastasis causing a small bowel obstruction, knowing full well there are probably several other tumors there as well. I look for specific etiologies of small bowel obstruction, and here's the case I just showed. This is a patient whose transition point was in this inguinal canal where there was an incarcerated inguinal hernia, and as I indicated to you, the multiplanar reformations nicely show sometimes the specific transition point in patients with small bowel obstructions. So that gets to, in the patients that we see, when do I worry? I worry when I think there's strangulation or ischemia present. We'll talk about that. Patients with high-grade obstruction are more likely to have problems than patients with a low-grade obstruction. Duh, I mean, that kind of makes sense. I think patients with some structural defect like an internal hernia or an external hernia are more likely to have complications. If there's any evidence of a twist, a volvulus or a twist, if there's any evidence of a closed loop obstruction, which I'll talk about, which are also at risk for volvulus, and then look really hard for signs of ischemia, which ought to send a patient to the OR tonight, not tomorrow. So yeah, I look for something a surgeon can fix. So here's an example of a closed loop obstruction from adhesions. There's an adhesion going from here to here. You can't typically see the adhesions on CT. They just are not really detectable. And so when you see a point of transition without a specific etiology, you can infer that that point of transition is an adhesion. Now, what is a closed loop obstruction? I think it's confusing. So think of like a ski sock, right? A sock that comes up to your knees. If you were to pinch that sock at both ends, that's what a closed loop obstruction is. And so you've got bowel contents coming down into this closed pinched loop of the sock. So you're going to have obstruction up to that point, but then this loop that's excluded continues to secrete fluid into the lumen. It gets distended. It's still peristalsine, by the way. It gets distended, and that loop now is obstructed, and the distal bowel beyond the pinched loop of your tube sock is decompressed. So it's an obstruction where there's the obstruction up to the closed loop obstruction, and then there's the closed loop itself, which is this isolated segment of bowel that's excluded on both the afferent and the efferent aspects that gets progressively distended. In this particular case, it's an uncomplicated and partial closed loop obstruction, so a fluid-filled loop of bowel pinched off here and pinched off here. And this is a picture that Dr. Balthazar wrote. It sort of shows what this might look like caused by an adhesion. So look for things like a closed loop obstruction that a surgeon can fix. I look for things like incarcerated ventral hernias, like in this particular case right here. Dilated loops of bowel, decompressed distal bowel coming out of the hernia. That's the cause of the obstruction. That patient probably needs to go to surgery for a repair. I already showed this case of the inguinal hernia, and the multiplanar reformations or the coronal and sagittal reformations are very helpful. Here is a patient with an obturator hernia. Obturator hernia is a hernia in the obturator canal, not to be confused for a femoral or an inguinal hernia. And the obturator hernia is typically in multiparous women who are generally older in age, who have some pelvic laxity, and a knuckle of bowel falls into the obturator canal and becomes obstructed and incarcerated. Those hernias are kind of interesting because there's some obturator nerves that pass through this obturator canal, and patients can have characteristic dysesthesias in their medial aspect of their thigh based on physical examination. You can imagine this kind of hernia would be very difficult to diagnose based on physical examination, but it's important to look here when you see patients with small bowel obstruction, particularly if their transition point is in the pelvis, as this may be the cause of the obstruction. Here is what that hernia looked like on a coronal view. Here's a picture from Dr. Federley's textbook that shows nicely the obturator hernia. Here's a patient with a transmesenteric internal hernia after a gastric bypass. And after a gastric bypass, there are rents created in the mesentery and in the omentum. And there's altered anatomy, and through those rents, you can have loops of bowel that can herniate. And here's an example of one creating this iatrogenic internal hernia. Looks like there might be some ischemia in that loop as well. Gastric bypass patients are at risk, as you know. Patients with gastric bypass, and we see lots of them, are at risk for postoperative complications due to the altered upper GI anatomy that they have, and they require careful attention when they come through. They can get very sick very quickly. And as I indicated, this is the picture from Dr. Balthazar's paper where he talked about closed loop obstructions. They can be uncomplicated, or they can be associated with a twist in the loop of bowel. You can imagine if you've got this loop of bowel that's distended and peristalsing, it wouldn't take much for that distended loop of bowel to twist upon itself. And when that happens, you can have all kinds of complications. So here's the uncomplicated variety right here, this adhesion going across, picking off this loop of bowel from here to here. But you can imagine that loop of bowel could twist. If that loop of bowel were to twist, all of a sudden now you've got not only a tighter obstruction, but more importantly, you've got a twist in the associated mesenteric arteries and veins that supply that loop of bowel. And that bowel then will become very much at risk for ischemia. And here's an example with a closed loop obstruction. So obstruction up to the closed loop, then the closed loop right here. And at the transition point of the closed loop, the blood vessels that supply that loop of bowel are also twisted, hence the dusky appearing loop of bowel, the evidence of ischemia. And this patient needs to go to surgery soon, as that bowel is going to get infarcted and perforate, and the patient's going to have septic complications. So these blood vessels that supply that loop of bowel in the closed loop, when they twist, they also twist and give rise to an ischemic segment. Here's an example of one: dilated loops of bowel, patient quite ill from a small bowel obstruction. A little more further in the pelvis, evidence of dilated proximal loops of bowel, some decompressed small bowel. And then you come down to the mesenteric blood vessels, and you can see this twist in the mesentery. And then you come into this different loop of bowel, this C-shaped loop of bowel or a U-shaped loop of bowel, that there's more wall thickening, there's abnormal enhancement of the bowel wall, there's associated fluid around this loop of bowel. And so this is a closed loop obstruction. Obstruction up to the closed loop, and the loop itself is obstructed, and this particular loop proved to be ischemic. And it might have looked like that at surgery. So what are some signs of ischemia? And I think it's hard to make the diagnosis of bowel ischemia. I think it's okay to overcall it sometimes too. Surgeons will often ask you to tell them if the patient has ischemic bowel. And be careful, because it's more than just a radiographic diagnosis or a CT diagnosis. The clinical is really important. And so to rely only on imaging, I think, is a mistake, and sometimes an inexperienced surgeon might do that. So anyways, you see bowel wall thickening almost always. Sometimes the bowel wall thickening is high density because you can have blood in the bowel wall. You have, rarely you can have like paper-thin loops of bowel. I'll show an example of that, but it's pretty rare. You almost always have fluid around the ischemic loops of bowel. If not fluid, you have mesenteric edema that's on its way to free fluid around the loops of bowel. You often have abnormal bowel wall enhancement. If you're giving positive oral contrast, it's hard to see that abnormal enhancement. You may have enhancement of the mucosa, enhancement of the serosa, enhancement of both, or you may have decreased enhancement. You may have decreased enhancement. You'll get edema in the adjacent mesentery almost always. And then associated signs with ischemia are patients who have a volvulus. So what are the signs of a volvulus? A twist in the loop of bowel, so you get the beak configuration that you know from working with barium. You get the twisting of the blood vessels as the loops of bowel twist. The blood vessels that supply them twist as well. Scanning up and down in the PAC system is very helpful to find that twist. And then late stages, perhaps stages associated with bowel infarction, include pneumatosis and portal venous gas. We're not that good at detecting ischemia. The literature is a mess. The studies are retrospective. The patient groups are highly selected. There's little path proof because ischemia can resolve, and so you can have a patient who looks like they're ischemic and or they get better, or a patient who looks like they have ischemia, and by the time they go to surgery, the ischemia is resolved. Surgical findings are often inaccurate. The ischemia sometimes is limited to the mucosa, and the surgeon will see the bowel from the perspective of the serosa. An endoscopist might see it from the mucosa, but a surgeon may see a viable serosa, but the mucosa may be ischemic. So it's a tough diagnosis. We need to do better with bowel ischemia. We're not that good. So you see wall thickening. I got a bunch of cases. You see wall thickening all the time. And you see mesenteric edema, and you see free fluid. And those are findings that raise the possibility of bowel wall ischemia. On a pre-contrast scan, you may see high attenuation in the bowel wall. I borrowed this from the literature because I haven't seen this very often in my practice, but that high attenuation in the bowel wall is fairly specific for the presence of bowel wall ischemia. Obviously, if you give IV contrast, it's going to be tough to make that diagnosis. Here's this example of paper-thin bowel wall, borrowed from my colleague Chad Miller. This patient went to surgery and had transmural infarction of their small bowel, and their bowel wall was like paper thin. And I think that's due to loss of the nervous tone in the bowel. And we haven't seen that very often, but that's been reported. You get edema in the mesentery. Almost always. There's another example of a closed loop. These closed loops often have a C-shaped configuration or a U-shaped configuration. But when you have ischemia, you'll have fluid in the adjacent mesentery. Of course, you can have fluid with infectious bowel disease as well, but rarely will you have ischemia unless there's some fluid in the leaves of the mesentery or edema. You'll see abnormal mucosal enhancement. So here's an example of where you see enhancement of the mucosa, enhancement of the serosa, the muscularis propria layers of the bowel wall, or the middle layer looks fine. That abnormal enhancement is nonspecific. You can see it with inflammation, but you can also see it with ischemia. Or in this particular case, another example of a closed loop. This is the ischemic closed loop, abnormal enhancement of the mucosa and the serosa with an edematous bowel wall. That patient proved to have a ischemic closed loop, and here's the dilated loops of bowel, not ischemic, up to that closed loop. The normal bowel wall enhances, but the enhancement's variable. So we're scanning very quickly now. And so if you're at about 40 to 70 seconds after contrast has begun, it's possible that the loops of bowel that have received their contrast earlier, which is usually going to be the jejunum, as opposed to later, like the ileum, you can have differential enhancement just because the distal bowel hasn't gotten the contrast yet. So be aware of that. Contrast enhancement of the bowel on a dynamic portal venous phase scan can be quite variable. Having said all of that, here's an example of decreased enhancement of loops of bowel in the right abdomen, normal enhancement of loops of bowel in the left abdomen. This is a patient who clinically looked like they had dead bowel. They had complications following an aortic repair, and it's a nice example of lack of enhancement in a patient with ischemic small bowel. and their bowel might have looked like that pathologically. Or in this case, there's some motion artifact and so on, but the loops of bowel here in the left abdomen are enhancing normally. Loops of bowel in the right abdomen are not. And these loops of bowel prove to be ischemic in this particular patient. Or in this one, normal enhancement in the upper abdomen, but abnormal enhancement down here. Pretty darn subtle, no question about it. The loops of bowel in the left abdomen here look more normal. These are jejunal loops. The ileal loops, however, look like decreased enhancement. And that patient proved there's also some fluid mesenteric edema. The right clinical scenario, that patient had dead bowel. Another example of the mesenteric edema and fluid that you often see with ischemic bowel. This patient also had a closed loop obstruction. Now, dual energy CT might be helpful here. Turns out our colleagues in University of Wisconsin have looked at this both in patients as well as in laboratory animals, and because you can have these iodine-only images that show you increased attenuation due to iodine, and because you can adjust your techniques to close to the K edge of iodine, any enhancement or any hypoenhancement becomes more conspicuous. Those subtle changes in bowel wall enhancement become more obvious with dual energy CT. That's clearly been shown to be true in dogs, and I think it's true in humans as well. Here's a case that Megan Lubner from the University of Wisconsin sent me, and it's a patient with florid dead bowel, pneumatosis, portal venous gas, no trouble with the diagnosis. But if you look at the iodine material density images, so here the high density in the bowel is due to iodine signal. These loops of bowel in the more anterior abdomen are clearly enhancing, whereas these loops of bowel here in the left abdomen that also look dead and also have pneumatosis aren't enhancing at all. And so I think for subtle degrees of enhancement, which is what you're looking for in ischemic bowel, dual energy CT could be helpful. I also mentioned this. I said that this high density in the bowel wall due to hemorrhage is really difficult to see if you give IV contrast. But if you use dual energy CT technique, you've got the virtual non-contrast scan there, and you can see that high density. We're looking at that at Duke and seeing how helpful dual energy can be for identifying patients with ischemic bowel. Here's one from our practice. Here's one from our practice where the left colon in this case does have some normal iodine signal in it, but the right colon in this case has no iodine signal in it whatsoever, and this right colon proved to be ischemic in this particular patient. So we're working on the use of dual energy CT for this scenario. I mentioned it's important to look for evidence of a twisted blood vessel. Here's the so-called whirl sign. Looks a little bit like a hurricane map coming on up from the Gulf Coast. And obviously there's a bunch of diseased loops of bowel associated with this twist in the mesentery. Look for that in patients with small bowel obstruction. That's a finding that indicates a volvulus, sometimes with a closed loop or sometimes without a closed loop, but it's clearly a twist. So look for twisting mesenteric blood vessels. Oh, yeah. So we're humbled sometimes by ischemic bowel. Here's a patient who came in with abdominal pain. As I alluded to this morning, this patient got a renal stone CT, and it probably shouldn't have got a renal stone CT. We didn't give any contrast, but we did see, and it doesn't project very well, some increased attenuation in the mesentery. And so we were worried about this person's GI tract, and then probably some pneumatosis. And to the point made this morning, going to bone windows or lung windows is pretty helpful for pneumatosis. And so we were worried about the viability of the bowel. Well, it turns out this person happened to have a CTA a few days previously. Not to point fingers, but it wasn't at our practice, but it certainly could have been. And actually the CTA looks pretty good except for some calcific aortic and iliac disease. But on the axial thins, there's a branch of the mesentery that has a filling defect within it. And this CTA was done a few days earlier. And that filling defect wasn't seen until that case was looked at in retrospect. The point is, if you raise the possibility of bowel wall ischemia, look really carefully at the vasculature. Because you can, particularly if you're a trained abdominal imager, you're not very good at looking at the blood vessels that come off the aorta. Or you may not look at them as much as you should, but you need to. So every time you put the word bowel ischemia in your report, take a moment to look at the celiac axis and its branches, look at the superior mesenteric vein and the portal vein and all of their branches as well to look for a subtle filling defect, or in this particular case, postoperative abdominal pain, had some pneumatosis in this loop of bowel. We thought that loop of bowel might be pneumatosis over here too. Thought that loop of bowel might be ischemic, and it's really important though to go ahead with your eyes and track the SMA on down and look at the filling defect in the SMA. Those filling defects in the SMA are out there, and I can tell you they're easy to walk by because at Duke University we walk by them not infrequently. So take a look, make that part of your search pattern. If you talk about bowel ischemia in your report, take a moment to go back and look at the blood vessels. Now, speaking of pneumatosis, here's a nice example of pneumatosis. I think pneumatosis is often a late stage, often associated with bowel infarction, although not always. Nice example of pneumatosis in this particular case. I think it could be a tricky diagnosis by radiography and a tricky diagnosis by CT. Here's another patient with pneumatosis. And one of the nice things about pneumatosis is if you're not sure about the presence of pneumatosis, but you see bubbles of gas in the adjacent veins that are draining those diseased loops of bowel, that's going to be pneumatosis, right? You're not going to get gas in those mesenteric veins unless there's gas in the bowel wall. So look at that finding as well, and that can be particularly helpful. Here's an example of the world's worst portal venous gas and the world's worst pneumatosis. So to conclude, when I see small bowel obstruction, I look for the point of obstruction and look for the specific etiology. I look for things that a surgeon might want to fix and look for signs of ischemia. In particular, is there a twist in the blood vessels? Are there any findings of ischemic bowel that require getting on the phone and talking to a surgeon? And with that, I will say thank you very much.